My name is Dr. Richard Pratley. I'm the Samuel Crockett Chair in Diabetes Research at the AdventHealth Translational Research Institute in Orlando, Florida. We know that chronic kidney disease is a very common complication of type 2 diabetes. About 40% of people with type 2 diabetes will develop chronic kidney disease. In 2021, this was 536 million people, and that number is expected to grow by 46% over the next 20 years. We have evidence that the GLP-1 receptor agonists may have a benefit in the management of patients with chronic kidney disease. This is important because although we have ACE inhibitors, ARBs, now MRAs, and even SGLT2 inhibitors, the residual risk for chronic kidney disease progression, as well as cardiovascular disease, remains high in this population. GLP-1 receptor agonists have been shown to have a benefit in meta-analyses of cardiovascular outcome trials. But these trials weren't designed as dedicated kidney trials. FLOW was the first dedicated kidney outcomes trial with a GLP-1 receptor agonist. We looked at both kidney outcomes as well as cardiovascular outcomes. FLOW was a multinational randomized controlled clinical trial. We enrolled patients with type 2 diabetes and kidney disease. Patients had to be less than A1C of 10%. All were on RAS inhibitors at the maximally tolerated dose. They had to have an eGFR between 50 and 75 milliliters per minute per 1.73 meters squared per minute with a UACR above 300, or an eGFR between 25 and 50 and a UACR above 100. They were randomized in a one-to-one fashion to once-weekly semaglutide, 1 milligram, plus standard of care, or to placebo. This is an event-driven trial, and we were looking for the primary outcome, which was a composite of a 50% reduction in eGFR compared to baseline, kidney failure, which was defined as a persistent decrease in eGFR to less than 15, or the initiation of kidney replacement therapy such as dialysis or kidney transplantation, or kidney death or CV death. What we found in FLOW is that, first of all, this was a very high-risk population. The event rates among patients with chronic kidney disease and diabetes at about 4 years, almost 6% had experienced this primary outcome in the placebo-treated groups. We found that semaglutide decreased the risk of the composite primary outcome by 24%, a highly significant result. Some of the important findings in FLOW were that the benefits of semaglutide on the primary outcome, as well as most of the secondary outcomes, were independent of the clinically relevant subgroups, such as sex, age, BMI, and the presence of background medications. We also don't think that the effects of semaglutide were mediated by changes in body weight or changes in hemoglobin A1C. One of the interesting findings in the FLOW study, though, was a significant decrease in heart failure. Now, this wasn't designed as a heart failure study, but patients with type 2 diabetes and chronic kidney disease are at very high risk for heart failure, especially heart failure with preserved ejection fraction. In the FLOW trial, we found that about 19% of people had heart failure upon admission into the trial. A number of people developed heart failure events during the trial. This was a fairly high incidence. What we found was that semaglutide decreased the risk of heart failure events or CV death by 27%, very highly significant results. This was true for both heart failure events alone as well as CV death. So overall, we found that semaglutide had a substantial cardiovascular benefit in patients with type 2 diabetes and chronic kidney disease, in addition to the pre-specified benefits on chronic kidney disease progression. Well, we had a number of secondary outcomes as well. The first outcome that we tested after the primary outcome was a change in GFR. And here we found that semaglutide reduced the decline in eGFR by 1.16 milliliters per minute per 1.73 meters squared per year. That was a highly significant benefit compared to placebo treatment. We also looked at change in eGFR measured by cystatin. And that also was significantly better in semaglutide-treated patients, as was the change in urine albumin to creatinine ratio. Now, this patient population had a very high risk for cardiovascular disease. At 4 years, almost 4% per year had experienced a CV event. We found that semaglutide decreased the risk of major adverse cardiovascular outcomes, that is, CV death, MI, or stroke, by 18%, a significant outcome. And then finally, we looked at all-cause death, or all-cause mortality. And here we found a 20% reduction with semaglutide treatment compared to placebo. Again, a significant outcome. So we were overall very pleased that both the primary outcome as well as the secondary outcomes were all significant. The FLOW trial answers the question about whether or not GLP-1 receptor agonists are effective in reducing the risk for progression of chronic kidney disease as well as CV outcomes in patients with chronic kidney disease and type 2 diabetes. What we don't know from this trial is whether or not the benefits would also apply to people with CKD without type 2 diabetes. There's a suggestion from the SELECT trial in patients with obesity and cardiovascular disease that semaglutide also reduced the risk of CKD progression in that population. But that wasn't a dedicated trial. So the next thing I would like to see is a dedicated trial in patients with CKD, but without diabetes.